The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar in the Public Health webinar series on blood disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. My name is Sujit Sheth. I'm professor of pediatrics at Weill Cornell Medical College in New York and direct the New York Comprehensive Thalassemia Center. I'm delighted to be with you today to moderate this inaugural webinar on thalassemia in the Public Health webinar series. Our topic today is thalassemia management, balancing blood and iron. Before I introduce our guest speaker, I'd like to go over a few points and helpful tips for joining this webinar. Upon joining, you will see two audio options. You can opt to listen via the speakers on your laptop or use your phone to call in. If the phone option is chosen, the webinar toolbar will provide you with the phone and access number and audio pin. All audio will be muted while the presentation is on. At the end of the presentation, there will be time for questions. To submit a written question, please use the question area in your toolbar. Keep in mind that you can enter questions at any time, but they will be saved until the end of the presentation, at which point we will answer them. Today's webinar will last approximately 1 hour. Please note that this will be recorded. So let's begin. We'll start today's webinar first with two brief audience polls. First, we're interested to know a little bit more about you. When the question pops up on your screen, please select your response. You can answer the question directly on your computer screen. You don't have to answer it in the control bar. So go ahead and answer now. Okay, seems like most of you have answered. Can we see the results? Okay, so it seems like the majority of the participants today are healthcare providers, about 52%, and another 17% are healthcare professionals, either in epidemiology, social work, or health educators, and then 22% are people either with thalassemia or thalassemia affecting a family member, and the remaining about 10% are community organizations or industry partners. So this is a very diverse mix. Let's go to the second poll question. Okay, go ahead and respond. Again, remember you can respond on the screen. Okay, seems like we have enough time for everybody to answer. I see that the majority, 85% of you are here in the United States, 2% from South America, 3% from Europe, about 10% from Asia, and the rest from Africa, Australia, and New Zealand. So it is a pretty diverse international audience, even though the majority of you are here in North America. So that was very useful to have that information. Now we will get started. So it is my great pleasure to introduce my friend and colleague and today's presenter, Dr. Janet Kwiatkowski. Dr. Kwiatkowski is professor of pediatrics at the University of Pennsylvania Perelman School of Medicine and director of the thalassemia program at the Children's Hospital of Philadelphia in Philadelphia. She's an expert on red cell disorders, knows more about thalassemia than anybody else I know, as well as sickle cell disease. And her interests include the diagnosis and complications of thalassemia, the management of transfusional iron overload as a whole, including in other conditions, as well as stroke and stroke prevention in sickle cell disease. Thank you, Janet, for bringing your expertise to this program. I now invite everybody to listen to this, which was going to be an excellent presentation. Take it away, Janet.
Thank you, Dr. Sheth, for that kind introduction. And thank you to the organizers at the Centers for Disease Control, as well as the Thalassemia Foundation for inviting me to give this talk. It really is a pleasure to be able to give the inaugural talk on thalassemia for this blood disorders webinar series. So I'll start with my disclosures, which are here, and then just to remind you of the learning objectives, which are also listed in the flyer that advertised this talk. So I'll start with the outline. What I'd like to accomplish today is first to provide some information on the pathophysiology of thalassemia and how we use treatment based on that pathophysiology. Then move on to transfusion management, and then monitoring of iron overload resulting from those transfusions, as well as an introduction to some basic principles of iron therapy. So the normal adult hemoglobin contains 2 alpha globins and 2 beta globins. And in the normal situation, globin synthesis is very balanced. So we have alpha-like globin chains, embryonic, but then more of the adult alpha globin, as well as beta-like globin chains, which include gamma globin or fetal hemoglobin, as well as beta or the adult globin. And this normally, the production of alpha and beta are equal, and that enables them to pair up and not have excess of either type of chain. However, in the setting of beta thalassemia, there's a reduction in the production of beta globin, and when you reduce the amount of beta globin, that leads to excess alpha chains, as is shown in the scale below. The reverse is true for alpha thalassemia, where there are excess beta globin chains. And it's really these excess globin chains that really cause the problems in thalassemia. So again, we start with a problem where there's a reduction in either alpha or beta globin production, leading to an excess of the opposite chain, either alpha or beta globin chains. This in turn leads to apoptosis or death of the early red cell precursors, the erythroblasts in the bone marrow, and that's what we call ineffective erythropoiesis. It also leads to damage of the red blood cell itself, the skeleton of the red blood cells, which leads to hemolysis or breakdown of the red cells. The ineffective red cell production causes the bone marrow to become extracellular, increased in production of bone marrow, and so you get bone marrow expansion, and also get what's called extramedullary hematopoiesis, or pockets of red cell production that are outside of the bone marrow, the usual place. Clinically leads to some changes in the bone structure, so you can see frontal bossing or an enlarged forehead, maxillary hyperplasia, bone fractures, hepatosplenomegaly, spinal nerve compression, and thinning of the bones or osteopenia. The damage to the red cell cytoskeleton or hemolysis, as well as the ineffective red cell production, also lead to anemia. The hemolysis and the damage to the red cells contributes to a hypercoagulable state or prothrombotic state as well. And this combination of anemia as well as hypercoagulability leads to other complications of thalassemia, including a propensity to clot, leg ulcers, silent cerebral infarctions, pulmonary hypertension, and then symptoms of anemia of pallor, fatigue, poor growth in children, early heart failure if not treated, and with hemolysis, an increased risk of developing gallstones. Having anemia also leads to an increased absorption of dietary iron, which I'll talk a little bit more about later, and sometimes leads to the need for red cell transfusions. And so with the increased absorption of dietary iron and red cell transfusions, this in time can lead to iron overload. And iron overload then causes heart complications, including heart failure and arrhythmias, liver problems, including scarring or fibrosis, as well as an increased risk of hepatocellular carcinoma, and a variety of endocrine disorders, including hypothyroidism and diabetes. So the treatment of thalassemia, there are 2 possibilities. The first, and what we really prefer, are curative therapies, which include hematopoietic stem cells, which the approved right now is hematopoietic stem cell transplantation. The problem is that not everybody will have an appropriate donor to undergo a bone marrow transplant. Gene therapy is currently in clinical trials, and hopefully sometime in the not too near future, this may be an option as a curative therapy as well. But today I'm actually not going to speak about curative therapies. What I'm going to really focus on is our conventional therapy, which includes regular red cell transfusions and then iron chelation to manage to control the iron loading from those red cell transfusions. I want to take a little bit of a step back and just talk a little bit about terminology here. What we nowadays use to describe thalassemia is either transfusion-dependent thalassemia or non-transfusion-dependent thalassemia. And it's important to note that this is really a clinical diagnosis. It's basically whether or not a family and their physician decided that red cell transfusions were indicated. And there's certainly overlap as far as genotypes or the genetic mutations that underlie the different thalassemia disorders and whether or not they're transfusion dependent or not. So for example, a beta-0 mutation where no normal beta globin is produced is usually transfusion dependent, but in the setting of some other modifying factors such as an alpha thalassemia or mutations in genes controlling fetal hemoglobin production, that actually can become a non-transfusion dependent thalassemia. And so what you can really see here is that there's tremendous overlap, and genotype alone does not predict does not completely predict whether or not someone will require transfusions or not. In general, transfusion-dependent thalassemia tends to present at an earlier age, somewhere usually for beta thalassemia, somewhere usually between about 3 months and 2 years of age, whereas non-transfusion-dependent thalassemia may present at older ages. The anemia tends to be more severe in transfusion-dependent thalassemia compared with non-transfusion-dependent thalassemia. And by definition, in transfusion-dependent thalassemia, regular transfusions are administered, whereas in non-transfusion-dependent thalassemia, it may not require any transfusions or intermittent transfusions. The complications of the two also differ in that in well-transfused thalassemia, the primary complications are really related to transfusions and iron overload, whereas in non-transfusion-dependent thalassemia, the complications are more due to anemia and ineffective red cell production. So how do you decide whether to start red cell transfusions and when to start red cell transfusions? So in other words, how do you know if somebody is now transfusion-dependent thalassemia? Well, we use laboratory criteria as well as clinical criteria to make this decision. Laboratory-wise, it's usually severe anemia, which is defined as a steady-state hemoglobin of less than 7 grams per deciliter. So not an intermittent low value in the setting of an illness, but really a persistent hemoglobin level that is low. But hemoglobin level alone is not enough, and you can also have clinical criteria even with higher hemoglobin levels, so hemoglobin levels that may be 8 or 9 if there are symptoms. And those clinical criteria include in children, poor growth and weight gain, bony deformities like the frontal bossing and maxillary hyperplasia, symptomatic extramedullary hematopoiesis, so pockets of red cell production that may be pushing on nerves and causing pain. Fatigue or significant impairment of activity, and then other complications that may develop often in older patients, including pulmonary hypertension or chronic pain. So then what are the goals of transfusion? Well, the goals of transfusion in thalassemia are somewhat different than in patients who have either hypoproductive anemia, so we're just not making enough red cells, or in the setting of an anemia, for example, in a patient with cancer who has anemia related to decreased production of red cells from the chemotherapy. So we do want to correct the anemia, but also want to suppress the ineffective red cell production. And that's an equally important goal of transfusion. In parentheses, I have there limit iron loading. Transfusions do two things. In the setting of good transfusions, the iron absorption will be reduced, but this is not really as important because you do get extra iron loading with the red cell transfusions themselves. And we like to administer red cell transfusions in a way to limit iron loading, but not at the expense of not suppressing ineffective erythropoiesis or correcting the anemia. And I'll get to that in just a little bit. So how do you determine the optimal pre-transfusion hemoglobin level then? Well, there were some studies done by Dr. Gazzola and his colleagues back in the 1990s that tried to look at the level of hemoglobin, where you needed to keep the hemoglobin level in order to suppress red cell production enough so that you would not get the complications related to that really hyperactive marrow. And if you look at the graph on the right, that looks at a marker called the serum transferrin receptor, or soluble transferrin receptor, and that goes up. It's a marker of increased erythroid activity, and you can see that corresponding value on the y-axis on the right. Looked at different pre-transfusion hemoglobin levels and how active the marrow was at that particular pre-transfusion hemoglobin level. And what you can see is that at lower hemoglobin levels of 8 or even 9, there were many, I'm going to try to use the pointer, many patients who had pretty marked erythroid activity. And as the hemoglobin level went up, the amount of bone marrow erythroid activity went down. And so if you look at that in table form, if you, in general, if the pre-transfusion hemoglobin level was kept somewhere between the 9 and 10 gram per deciliter range, that suppressed the soluble transferrin receptor activity and suppressed red cell activity to somewhere between 1 and 4 times normal. And so generally, that's the values that we use, is somewhere between 9 and 10 grams per deciliter to say that that's adequate. If you bump that level up to 10 to 11, you might get a little bit more suppression of the marrow. But importantly, if the hemoglobin level goes below, the red cell activity increases, and that's when you can see complications from the ineffective red cell production. The same group also looked at the pre-transfusion hemoglobin level and how much iron loading there was. So if you push the hemoglobin level up higher, does that translate into a higher amount of iron loading? And the short answer is yes, to some extent. And so what they did is they looked at 32 patients who had been kept at a higher hemoglobin level of 10 to 12, and then they switched the patients to having a pre-transfusion hemoglobin level that was lower in the 9 to 10 grams per deciliter range. And what they found is that maintaining a higher hemoglobin level increased the transfusion requirements, so about 137 mils per kilo per year versus 104. And in addition, when looking at the patient's iron stores, they found that the ferritin levels were higher, significantly higher in patients who had their hemoglobin levels maintained at a higher goal. So generally, maintaining the pre-transfusion hemoglobin level of 9 to 10 grams per deciliter not only seems to be good for suppressing the native red cell production, but it also seems to limit iron loading. Now, some people need higher levels, and it's not that you can't do that. You just have to be able to match the iron chelation to take out the extra iron that you're getting. So in addition, keeping the transfusion with a moderate or hypertransfusion regimen to maintain the hemoglobin level greater than 9 grams per deciliter is also associated with clinical benefits, including improved growth in children, less organomegaly, so less hepatosplenomegaly, fewer fractures, less facial deformities, and less impairment of normal activity. So people just felt better with a higher hemoglobin level. This is just a graph from a patient that was referred to me at age 10. This is a growth chart, and you can see that the child started with a growth that was at about the 90th percentile for weight, and gradually over time, between the ages of 4 and 10 years, had fallen off and now was down at the 25th percentile. We started at that point a regular transfusion regimen, and you can see that the growth improved, and his weight gain and height, which I'm not showing here, also improved and came back up to his genetic potential close to the 90th percentile. So there's definitely improvement in growth in children who are well transfused. So if I just summarize then the optimal pre-transfusion hemoglobin level, we generally recommend a transfusion regimen to keep the pre-transfusion hemoglobin level greater than about 9 to 9.5, 9.5 being sort of in the middle of that target of 9 to 10. And this level adequately suppresses erythropoiesis, or red cell production, and also limits red cell intake and iron overload, and is associated with clinical benefits. Now, I should mention that maintaining a higher hemoglobin level is appropriate in certain situations. One is if the patient continues to have evidence of marked increased erythropoiesis. That would include markers such as a high nucleated red blood cell count, or if you see clinical manifestations such as bony deformities that are developing or poor growth, then a higher hemoglobin target may be needed. Some patients still have clinical symptoms even when their hemoglobin level is in the 9.5 gram per deciliter range, and they may benefit from having a hemoglobin level maintained greater than 10. There are patients who still have significant fatigue or pain at lower hemoglobin levels, and then a higher hemoglobin level would be appropriate. And then there are certain clinical scenarios, including in the setting of heart failure and temporary situations such as pregnancy, where maintaining a higher hemoglobin target is appropriate. So this always should be a conversation between the physician, the treating physician, and the patient to determine what is best for each individual. So this slide shows the results of a project that was done in coordination with, funded by HRSA and done in coordination with the Cooley's Anemia Foundation and 3 thalassemia treatment centers, including Dr. Sheth, myself, and Dr. Lau at Oakland Children's. We tried to develop guidelines that would help clinicians to manage transfusions, and also looked at other topics, including management of or monitoring of iron overload, which I'll talk about later, as well as the management of some certain chelator toxicities. And I want to point these out because these are available on the Cooley's Anemia Foundation website, which is listed below. These were constructed based on an extensive literature review, as well as and then feedback from a number of experts in the field. And so this particular checklist shows it sort of practically how do you manage transfusions for patients with thalassemia. So if you look at the table, the left column shows the pre-transfusion hemoglobin level, and our target really, we said, was to keep the hemoglobin level between 9.5 to 10.5 grams per deciliter. And if you're at that, if the patient comes in and has a hemoglobin level in that range, then you should really just continue the current transfusion regimen. And a typical transfusion regimen for a child might be somewhere between 10 and 15 mils per kilo every 3 to 4 weeks, and for adults, 2 to 4 units in the same time interval. If the hemoglobin level fell lower, so between 8.5 and 9, and just below 9.5, then the recommendation would be to increase the transfusion volume slightly, so by 15 to 20%. To try to get that hemoglobin level back to target, and conversely, if the level was too high, to just reduce the transfusion volume. It's always we found that it's better to just adjust the transfusion volume rather than either have the patient leave and come back later for a transfusion if the hemoglobin is too high, or to have the patient come back more frequently if the hemoglobin level is just slightly low, and that's because it's very disruptive to patient schedules to always be switching around transfusion dates. In the setting of a very low hemoglobin level, however, sometimes they may need to, especially if it persists, to consider changing the transfusion schedule, where maybe you're on an every 4-week schedule to go to an every 3-week schedule to try to keep that hemoglobin level up higher. So if I just want to summarize then the management of transfusions, the general principles, it's generally best to keep to a regular schedule, such as every 3 or 4 weeks, and that really minimizes disruptions to patient and family schedules. So many people have taken off from work or notified school that the child would be absent, and if you change that schedule, then that can make things quite difficult for families. If the hemoglobin level is below target, then you should increase the volume of red cells transfused to a maximum of 20 milliliters per kilogram. For children, it's important to balance that volume with the possible need for an additional unit exposure. And what I mean by that is that if your calculation just winds up that you're going to give 30 mLs more, and you have to break into a second unit for that, it may not be it likely is not worth that additional exposure. So there are some practical issues for small children. If the hemoglobin level is above target, then the volume of red cells can just be decreased instead of moving the transfusion date. And just to remember too, if the hemoglobin level is unexpectedly low, it's important to work up for a cause for that, either a delayed hemolytic transfusion reaction, was the patient recently ill and that caused some increased hemolysis, is there marked splenomegaly, which is increasing transfusion requirements, or is there some blood loss that that may be contributing to a lower hemoglobin level, such as with gastrointestinal bleeding with deferocerox. So then looking at next the optimal product to give to a patient, the question is how well do you match the red cell antigens? And so to get an idea of that, we looked at, if you look at the red blood cell alloimmunization rate in beta thalassemia, in the Thalassemia Clinical Research Network, we found that about 16.5% of patients had developed red cell alloantibodies. That rate really varies quite a bit by site, from no alloimmunization all the way up to almost 40% of patients having alloimmunization, probably due to a variety of factors, including the discordance between antigens in the donors and the recipients, which I'll mention a little bit more in the next couple of slides. But what's important is this table shows the different antigen specificity, so what the alloantibodies were directed towards. And what you can see in these red boxes is that the vast majority of antibodies that develop are targeted to the RH system, so D, but also C and E, as well as Kel. And so that can sort of help us decide what we should best match against prophylactically in patients. Some of the risk factors for alloimmunization included older age, so those who were alloimmunized were close to 30 versus 20 years old for those who did not have alloimmunization. Race affected risk. Splenectomy, so patients who were splenectomized had a higher rate of alloimmunization than non-splenectomized patients. And age of transfusion start may also be important, and this has been shown in a couple of studies now, where the rate of alloimmunization tends to be lower if transfusions are started at a younger age. Here, less than 1 year had an 11% rate of alloimmunization compared to a rate of 18 to 31% in those who were older than a year when they received their first red cell transfusion. But really the greatest predictor was the number of years of transfusion, and that probably has to do also with increased donor exposure. So the more years you're transfused, the more red cell units you've been exposed to. So what do we practically do then for antigen matching? So typically it's recommended to, at a minimum, match for ABO, RHD, as well as the CE and Kel antigens. It's also important to obtain a prior history of alloimmunization. So patients often have received transfusions at multiple different hospitals. And so you want to really check with those blood banks as if there was a history of an antibody or not, because those antibodies may not still be detectable, but the memory will be there. And so you can still develop a delayed hemolytic transfusion reaction. And so you want to provide antigen negative blood based on the alloantibody history as well. What about extended antigen matching? Some centers do this routinely. This is in a very small study of 18 patients out of at a hospital in Italy. They looked at, these were mainly children with a mean age of 15 years who had not previously been alloimmunized. And what they did is they did sort of conventional matching, which was the ABO, D, C, E, and Kel for a year, and then they switched them over to extended antigen matching, adding Duffy A and B, JKA and B, MN, S, and S antigen matching, and compared alloimmunization rate. And actually what they found was that neither group developed alloantibodies. So you would think that that means, well, just the lesser matching may be enough, and that may be true. But I just would caution that there may be some situations where it's beneficial to do more extended antigen matching, and that would be in situations where there's phenotypic discrepancy between the donors and recipients. So what are some other considerations for red cell products? Well, we recommend leukocyte depleted. This is typically now done pre-storage, but can also be done with a filter at the bedside. And then one question that comes up a lot is the age of the red cell unit. So typical red cell storage is first of all refrigerated, and then depending upon the additive, the shelf life is it's about 35 to 42 days, 35 being for CBDA, 1 preserved cells, and 42 is extended shelf life if you add sol. But we know that when you're storing red cells, that there is a storage lesion that occurs to the red cells. There's oxidative damage, there's loss of 2,3-DPG, also known as BPG, and decreased energy source or decreased ATP, as well as damage to the red cell membrane and release of free hemoglobin with this microparticle formation. And all of that really translates into the possibility of decreased recovery of the red cells and also reduced survival of the red cells. There's a lot of debate about this, and in studies of acute transfusion, so in somebody who's having surgery, they really haven't found any effect in general on survival of patients who are treated with older red cells compared to younger red cells. But in a situation where you have chronic red cell transfusions and you can develop iron overload from that, you really probably want to have the best survival possible of the red cells. And so we typically recommend to use to transfuse with units that are less than 2 weeks old, if possible. Sometimes that's not possible if there's particular alloantibodies that you need to match better for, and or depending upon what blood supply is available. But that is the typical recommendation. So I want to move on now to iron loading with red cell transfusions. And it's important to know that you really want to monitor how much volume of red cells you're transfusing to a patient, because that helps you to calculate how much iron loading is going in and how much therefore you need to balance to get out with chelation. The way you can calculate that is that each milliliter of pure red cells, so we're talking about red cells with a crit of 100%, contains about 1.08 milligrams of iron. So to calculate it, if you have a patient who's getting 15 mils per kilogram of red cells every 4 weeks, and if these are adsol stored, so a crit of about 60% for the unit, the iron loading is the 15 mils times the crit, which is 60% or 0.6, times 1.08. And that comes out to about 9.72 milligrams of iron per kilogram every 28 days. So if you then divide that by 28 days, you wind up with a figure of 0.35 milligrams per kilogram per day. And then you know how much iron the patient is getting in. This table shows some typical iron loading in patients with transfusion-dependent thalassemia. These were data that were pulled from the trial on deferocyrox in patients with beta thalassemia. And what they found is that the average iron loading, about 60% of patients with thalassemia tend to have iron intake in the range of about 0.3 to 0.5 milligrams per kilogram per day, which corresponds to a yearly transfusion requirement of about 155 to 250 mils per kilo. About 20% of patients have lower iron loading, so iron intake of less than 0.3 milligrams per kilogram per day, and about 20% have higher iron loading of more than 0.5 milligrams per kilogram per day. So some variability, and you really do want to know what the individual patient's iron loading is. We did find in that same study that patients who had undergone splenectomy did have a slightly lower, about a quarter, 25% less transfusion requirements than patients who had intact spleens. Just one slide on iron overload in non-transfusion dependent thalassemia. Most of this talk has been focused on transfusion dependence, but as I mentioned earlier, in the setting of anemia in thalassemia, there is increased iron absorption. And the reason is that the ineffective red cell production in anemia causes an increase in erythroferrone and other factors as well. Erythroferrone then downregulates hepcidin, which is sort of the master regulator of iron absorption. And in the setting of low hepcidin, there's increased absorption of plant-based dietary iron, shown by the spinach, as well as release of iron from storage, from the macrophages. And both of those mechanisms lead to iron overload. In addition, patients with non-transfusion dependent thalassemia may sometimes get intermittent red cell transfusions, and those red cell transfusions will influence iron loading as well. Iron overload causes problems for a number of reasons, but one is that iron exceeds the ability of the carrier protein or transferrin to bind it, and when iron is not bound to transferrin, it's dangerous iron that can cause oxidative injury. And then this leads to liver inflammation and fibrosis, increases the risk of hepatocellular carcinoma, and as mentioned before, increases the risk of certain endocrinopathies, including diabetes, growth hormone deficiency, and hypothyroidism and hypogonadism. So how do you monitor iron overload? Well, there's a number of different methods that can be used. The easiest is a blood test, which is the serum ferritin level. It's cheap, and it is a simple blood test, so not difficult to obtain. There is some predictive value of ferritin, so levels greater than 2,500, steady levels greater than 2,500 do predict an increased risk of heart disease and other complications from iron overload. And because it's easy to get, you can really follow trends over time, and it's useful for adjusting iron chelation, though there are some limitations that I will get to. Liver biopsy is another way of monitoring iron overload. This is helpful because it also lets you see the histology, so you can see if there's scarring, if there's inflammation. The blue here, this is a picture of a liver biopsy. The blue is the iron stain, and so this is a patient who has high liver iron. The liver iron concentration is also predictive, so levels above 15 milligrams per gram dry weight predict an increased risk of cardiac disease and death. Also, higher levels predict a risk of hepatocellular injury, and that also it has an associated risk of hepatocellular carcinoma. But there are limitations to using both ferritin and liver biopsy in monitoring iron overload. So for ferritin, the value is altered by inflammation. Also so that raises the ferritin level, and vitamin C deficiency, on the other hand, can lower the level. So it may not be reflective of iron burden. The level doesn't always correlate well with hard iron. And trends in ferritin level are good often for adjusting iron chelation, but they don't always predict the trends in the liver iron concentration. And this, there was a publication on the use with deferocyrox, and what was found is that there were times when the ferritin level was not getting better, but the liver iron was. So in about 52% of cases that occurred. And then vice versa, sometimes when the ferritin level was improving, the liver iron concentration was either stable or getting worse. And so it's not perfect, but it does tend to, within a patient, if it's been useful before, it tends to continue to be useful. And so I think because it's easy to get, it's still a useful measurement, but it's not perfect. Liver biopsy also has problems. There's sampling error. If you get a sample that's too small, you may not have a good value. If there's areas of scar, fibrosis, you may underestimate liver iron concentration because there's not iron present in that scar. It's a painful procedure. There are risks, including bleeding and bile leak. And in young children, you need anesthesia. So that limits its acceptability. And the liver iron concentration doesn't always predict the cardiac iron level. So with that, we've really moved more to magnetic resonance imaging of iron burden where available. And there are different techniques for liver iron. Both R2 techniques and R2 star techniques have been used. These techniques correlate very well with liver biopsy results. They've been validated. It's important to remember still that the liver iron doesn't always correlate with the cardiac iron, so getting both measurements is helpful. When you get a liver iron result, it's usually been used a calibration curve, and so the results are not given as a Hertz, but instead as a milligram of iron per gram dry weight, which is the way we tend to think of things. And so high is bad and lower is good. Hard iron, really the ability to measure hard iron by MRI has really revolutionized patient care because now it enables us to predict who may be at risk for developing heart complications from iron overload and allow us to intervene before that complication develops. So it's usually a T2 star technique that's used, and values that are less than 20 milliseconds are considered abnormal, and very low values of less than 6 milliseconds predict that within a year there's almost a 50% chance of developing heart failure and a 14% chance of developing arrhythmia. And again, that's really important because here's a situation where you can then intervene and improve iron chelation to try to prevent that from happening. The pictures here show really what we're looking at. The picture on the left shows a patient with low iron loading. So this is the liver, and you can see a lighter color. There's a patient with high iron loading in the liver, and it's very dark. And dark is considered is what represents the iron. And then this is the heart septum, also in a patient who has a normal cardiac T2 star compared to a dark septum in a patient with significant iron loading. So there are some limitations to MRI of iron. It includes the high cost. Frequent studies are not practical, so you can't do this every month to follow trends. The availability, and I mean by availability also of validated techniques, because it's not good to just use your own, some different hospitals sometimes will just have their own way of developing an algorithm for iron overload, but it really needs to be a validated technique. The R2 and R2 star don't always correlate well, particularly at very low values or high values, so it is important to use the same method over time. But MRI of iron is less reliable at liver iron concentrations that are quite high, although at that level you know that it's pretty high and that you need to do more intensive chelation. Children will need sedation, and then if you have a pacemaker, you really can't have the MRI performed, and certain other metal implants may cause artifact with the MRI. So this is also a thalassemia checklist that Dr. Sheth took the lead on that shows how often should you be monitoring with MRI. And so our target range is usually to keep the liver iron in the 2 to 5 range and to have a normal T2 star. If that's the case, then we usually recommend getting your first liver iron concentration at the time when chelation is being initiated, and then to continue to monitor it annually. The T2 star, we usually say to start at age 10 and then can follow every 2 years thereafter. If you don't know the early iron chelation history and transfusion history, then we do start the cardiac T2 star a little bit earlier, just to keep that in mind. And then again, if you have a moderately elevated liver iron, you still want to continue to follow the liver iron yearly and probably do the cardiac T2 star closer to yearly as well. And then in the situation where there's very high liver iron loading, especially when intensive chelation is used, to monitor it even more frequently than yearly, so every 6 months. As well. And then similarly with the T2 star, when the values are quite low, instead of doing annual monitoring, you really want to do monitoring every 6 months, in addition to additional cardiac testing to look at cardiac function, including echocardiogram and evaluation with a cardiologist. So we know now about iron loading. So let's talk a little bit about getting iron out. So the goals of iron chelation are really to try to maintain a safe level of iron in the patient. Ideally, would be preventing accumulation of iron, but often we're also removing excess stored iron. Iron chelation can reverse organ function. The good news is that cardiac iron overload problems can be reversed with good chelation, and some of the endocrinopathies also may be reversed, but not all of them. Particularly, frank diabetes is not usually reversed with intensive chelation. But equally important is the need to detoxify that free iron, that non-transferrin bound iron, to prevent further injury. And we really like to have as continuous exposure to chelator as possible. So if you can have 24-hour exposure, that's really ideal, but longer is better. So so 6 hours is worse than having 24 hours of exposure. When do we start iron chelation? There's a number of different factors that you can consider. So some will say cumulative transfusion iron load of 120 milliliters per kilogram. That's usually after 10 to 20 transfusions. a serum ferritin level of greater than 1,000, and that's in a steady in a well when the patient is well, because if sick or inflamed, that level may be higher than the true reflection of the iron burden. A liver iron concentration of 5 or higher, and we usually say to start at age 2 years or older. Now, I will say that there is a recent pilot study of starting low-dose deferriprone, so 50 milligrams per kilogram in infants who had received only about 6 transfusions and had ferritin levels that were between 400 and less than 1,000. They randomized these infants, so half of them received early iron chelation and the other half standard, which was when the ferritin was greater than 1,000. And comparing those two groups, they found that the early deferriprone use delayed the time for the ferritin to rise to greater than 1,000. And also children had less exposure to that non-transferrin bound iron or the dangerous iron forms. And they didn't see any unexpected or serious adverse effects in these infants. It needs further testing, and there's actually a larger randomized study of deferriprone, and I think it also needs to be looked at with deferricyrox as well. But I think that we may come to the point where we start using iron chelation at younger ages. What iron chelators do we have? This table shows the 3 currently approved chelators in the United States and their different properties. The doses for transfusion-dependent thalassemia are shown in the top. Those doses are lower for patients with non-transfusion-dependent thalassemia who have iron overload. I want to just point out that deferricyrox comes in 2 different forms. One is a dispersible tablet. That was the first form approved, but more recently there's a film-coated tablet and granule form. The dosing for the film-coated tablet and granule form is lower. It's about 30% lower than with the dispersible tablet. So you just have to make sure you know which form you're prescribing when you're figuring out the dose. Deferoxamine was the first approved drug, and it's been around since the 1970s in clinical use, so a really long track record. But the problem with that drug is that it has to be given either subcutaneously or IV as a continuous infusion, which is burdensome to patients and painful. The main side effects are the local reactions that you can get, as well as hearing and vision or ophthalmological changes, and in growing children, a risk of some bone abnormalities, and all of those, particularly if the dose of the chelator is high relative to the amount of the iron burden. This drug is very good at removing liver iron and also removes hard iron as well, especially with continuous infusions. Deferriprone is the second drug. It's actually only approved in the United States as a second-line agent. It's given orally as either a tablet or a solution, but does require 3 times daily dosing. The most concerning side effect of deferriprone is agranulocytosis, or very low white blood cell count, which necessitates weekly blood count monitoring. But the benefit of this drug is that it's very good at hard iron removal, less so at hepatic iron removal, or at least there are differing reports, some that show good removal and some that show not as good hepatic iron removal, which may in fact be dose related as well. So higher doses, you may get more liver iron out. And then deferricyrox, which was approved back in 2005 in the U.S. for children aged 2 years and older with transfusion-dependent thalassemia, and 10 years and older for non-transfusion-dependent thalassemia. And this drug is also very good at hepatic iron removal. Studies have shown that it's equally efficacious to deferoxamine at hard iron removal as well. So generally a pretty good agent. The main side effects here are hepatic transaminitis and renal dysfunction and even a renal Fanconi syndrome that can be seen in a small percentage of patients. So how do you decide which chelation to use? So the choice of the product, it depends upon the availability, the cost and copays that patients may have, comorbidities, adverse effects, as well as the organ-specific iron loading, and the dosing is based on current iron burden, ongoing transfusional iron intake. The transfusion burden, we know that this table comes also out of the deferricyrox study. that patients the lower doses of both drugs, deferoxamine and deferocyrox, were not effective in reducing liver iron in patients with higher transfusional iron loading, and so you really do need higher doses for patients who have higher iron loading. And this table just shows what you should do with iron chelation. And you really want to adjust the dose based on how much iron is present. Cardiac iron is on the x-axis and liver iron on the y-axis. If you're in the green zone, that's a good range, and you want to just keep your iron going where your iron chelation at the current doses. But at higher levels, then you need to modify that chelation. If the iron burn's not improving, then you really need to just look at adherence. You may need to increase the dose or change the chelator, or even go on to combination chelation therapy. And I just want to end with saying that with good monitoring of iron overload and iron chelation, there's been a significant reduction in deaths from iron overload from 7.9 per thousand patient years to 2.3 per thousand patient years. And patients are living much longer. So to summarize, regular red cell transfusions should be administered to keep the trough hemoglobin level above 9 to 9.5. Iron burden should be monitored regularly. The choice of the iron chelator is based on a variety of factors, including patient preference, organ-specific iron loading, and adverse effects. And iron chelation should be administered to reduce accumulated iron and remove iron from ongoing transfusions. And with that, survival of individuals with thalassemia has really significantly improved. So I think we can move on now to questions.
So I'd like to thank Dr. Kwiatkowski for a really terrific webinar presentation today. And I'd like to thank all of you for joining us. We don't have a whole lot of time for questions, so I'm going to go through. I've gone through all the questions that we had that participants have submitted, and I'm going to pick a few of the sort of more common themes. The first is, can you comment, Dr. Kwiatkowski, on the use of hydroxyurea in terms of whether or not if you can get an increase in hemoglobin using hydroxyurea, that is as effective as transfusions or not? As well as, do you think that using hydroxyurea in combination with transfusions will reduce the transfusion requirements?
So that's a good question. I didn't talk about other approaches. Hydroxyurea may be beneficial in some patients, and what it does is it increases the fetal hemoglobin production. And it can, in general, the rise in hemoglobin levels is about 1 to 1.5 grams per deciliter, sort of on average. So probably not as helpful for somebody who has a very low baseline hemoglobin compared to somebody who might have a baseline hemoglobin of 7.5 or 8, where you can get the level up to a little bit higher. The dosing is a little bit lower than what we use in sickle cell disease. So we usually start at 10 milligrams per kilogram for the dose instead of 20 milligrams per kilogram, which is our usual starting dose for sickle cell disease. And that's because there's a little bit of a higher risk of neutropenia in patients with thalassemia. As far as effect on blood transfusion requirement, that's a little bit harder, I think. There are some patients who might get a little bit of a benefit from that, but I have found in general that that I haven't seen a really superior response or really reducing the transfusion requirements that much with hydroxyurea. But I think it's something that could be tried and may also help to reduce the ineffective red cell production in the setting of not being able to transfuse as much as you would like to suppress the marrow production.
Thank you. The next question is related to when you start chelation, and you presented some preliminary data on starting chelation under the age of 2. One of the questions was, we monitor ferritin levels and liver iron concentrations. What's the most reliable indicator that it's time to start chelation? Is it the ferritin level? Is it the liver iron concentration? Is it the number of transfusions, the volume of transfused blood?
Yeah, I think I don't think there's one right answer. I think we do typically know that after 10 to 20 transfusions that there will be iron loading, and so that's a pretty simple way of measuring figuring out when you should start. The ferritin level is probably one of the most commonly used because that's one of the easiest tests to get and doesn't require sedation for young children. So I would say the two that are probably used the most is just the number of transfusions as well as the serum ferritin being above 1,000.
Okay, thank you again for that. One final question. In terms of the feasibility of getting fresh blood, less than 2 weeks old or less than 10 days old, is that something that is recommended? And how does one go about facilitating that?
Yeah, so it can be hard, so there especially in places where there's limited blood supply. So blood banks often want to use up the blood that's about to expire so that it doesn't expire and they don't run down their inventory. But having said that, in areas where there are adequate blood supply or safe blood, I think it really requires talking to the blood bank and talking to the Red Cross or whoever the supplier is as well about the need to have fresher blood. It's not. It may not always be possible, even in places where there is inadequate blood supply, and that may be, as I alluded to before, if there's certain antibodies where you have to find antigen negative units, they may be a little bit more difficult to find, and so you might have to go with a little bit of an older unit. And it's not the end of the world, especially it doesn't have to necessarily be every single transfusion. I mean, we like to, in general, keep the blood as fresh as possible. But if you can't, or if sometimes you can't, it's okay.
Thank you. That's very helpful. So I don't think we have time for any more questions. I'd like to thank Dr. Kwiatkowski for a terrific presentation today. I'd also like to thank our colleagues at the Cooley's Anemia Foundation for hosting today's webinar. You will receive, all participants will receive an email shortly asking for feedback, so please respond with your comments. If you have additional questions about the presentation, please contact, again, you have this information in your invitation, Cindy Sayers at csayers@cdc.gov. This webinar will be archived and the content will soon be available on the CDC's Division of Blood Disorders website. You'll see that on the slide coming up in a second. And then I'd like to invite you to join us next month, March 7th. That's a week from today, when we will hear from Dr. Neil Goldenberg, Chief Research Officer at the Johns Hopkins All Children's Hospital and Director of its Clinical and Translational Research Center. Dr. Goldenberg will be presenting a scientific update on venous thromboembolism in children. So I'd encourage you to join that one as well. But otherwise, thank you very much to everybody for joining us today, and have a great rest of the day, night, wherever you are in the world. Thank you again.